Hello, everybody. Welcome, welcome. We are so excited to have everybody here for yet another Menopause 201 session. I am Dr. Rebecca Dunsmoor-Su. I'm the Chief Medical Officer at Genève. I'm also a clinical researcher. And just a disclosure before we start, although I don't have to do them because there's no CME, but I'm going to give you one anyway. We're going to talk a lot about some trials tonight, and our clinical research center ran all of these trials. So I do have some inside knowledge about, how they were conducted. So if people have questions about that, happy to answer. And I'm happy to introduce Dr. Hannah McDashie.
Hi, everyone. So I also work with Becca in Genève, and I'm also a certified menopause provider and a surgical gynecologist at the VA.
All right. So we're going to launch right in. There's a lot of content to get through tonight. We want to leave plenty of time for questions. So Hannah, take it away.
Yes, so today's topic is the riveting and exciting topic of
It
NK
is for
receptor
me.
antagonists. It's a really important topic. It's so NK receptor antagonists. So this is a class of drugs that have come on the scene the last couple of years. These drugs are a great option for management of vasomotor symptoms in women who, for example, can't take hormones. Think of women with hormone sensitive cancers, women who've had like DVTs and PEs. They're also a really good option for treating menopausal symptoms in women who are, let's say, beyond 10 years into menopause, beyond the age of 60, and are struggling with these VMS symptoms. They're a good option for patients who are, not interested in hormones. So think of the patients who, after WHI, got very concerned and they really want to avoid hormones at any cost. This is a good medication for these patients. So on that note, Becca, can you give us a little bit of the anatomy of the brain and how these drugs work?
Yeah, and I've done something this time that I have
Yeah.
never done before, which I actually made
Okay.
a slide.
What you
So I
can.
made a slide because I think it's easier to talk
Yeah.
through the anatomy of how these work with a
Yeah.
visual and a graphic. So
Yep.
we're going to start with the GnRH neuron. So obviously during late perimenopause and in menopause, that GnRH neuron is not accepting that the ovary is not responding to it. So it tends to pulse very, very quickly, trying to drive the pituitary secretion of FSH and the gonad to respond. And that response from the gonad would obviously feed back on the GnRH neuron and change the pulsing, but it doesn't get the feedback. Well, while that GnRH neuron is pulsing and sending signals to the pituitary, it is also activating a second set of neurons called KNDY or candy neurons.
Indeed.
That's candy neurons,
I know.
kispeptin,
It's so
neurokinin,
exciting.
dynorphin. And these neurons in the hypothalamus have a number of functions that, are unrelated to reproduction. But when you start stimulating them, that generates pulsatility has a positive stimulatory effect on these neurons. And they are using neurokinin to then transmit elsewhere in the hypothalamus to the warm sensing neurons. And so the warm sensing neurons are those neurons that tell our body that we are within a normal temperature range. So these warm sensing neurons just let us know that we're well within range and we don't need to do anything about cooling or heating. But when these candy neurons start signaling the warm sensing neurons over and over and over again, that normal temperature range goes from very big to very narrow. And so women start to exceed that temperature range all the time. And one of the things we do in our bodies when we exceed that temperature range is we tell our peripheral vascular system to dilate and cool us off. And so that is sort of how the brain communication is happening. So when candy neurons were discovered, they immediately became a target for, well, can we alter the signaling here, very specific to vasomotor symptoms, to help let those warm sensing neurons just sort of calm down and say, oh, yeah, maybe there is a broader range of normal temperatures that I can live in. So that's really how the development of these very specific neurokinin blockers came about. So Thank you all for coming to my sort of my neurology lesson. Um,
My
as best
favorite
I can
topic in
do.
med school,
Yeah.
neurology.
Yeah. So both of the new drugs to the market
Yeah.
target neurokinin. Um, and one of them, fezolinetant, is a selective neurokinin 3 receptor antagonist, and the other is a dual antagonist against NK1 and NK3. So, Hannah,
Yeah.
how do
Oh
these
my God.
like
Is
so
it a neurology quiz?
yes, no,
Okay.
not a neurology quiz. Um, so given that, is there anything you think we need to add to how they're working, how they are the same, how they are different?
Yes, so fezolinetant is, very selective to the blockade of NK3
Hmm.
receptors.
Yeah,
And then elezonitant is more, it actually has blockade of NK3 receptors, as well as the NK1 receptors. And we think that this additional like NK1 receptor antagonism may actually give you some theoretical advantages. And that's because NK1 receptors are actually involved in that peripheral vasodilation pathway. And they're also involved in primary insomnia. So it
right.
could be that that's why elezonitant is potentially more helpful than fezolinetant. And, but in the end of the day, whether this dual receptor blockade is actually going to translate into clinically meaningful differences, I think they're going to need to run more trials specifically on that.
Yeah, I
Um,
know, I agree with you on that.
yeah, so Becca, can you give us some like can we get into the details of, I mentioned briefly, well, we have two NK
Mhm.
receptor antagonists and they're slightly different. Can you give us some details about each one of them?
Yeah. So, what I wanted to do for everybody is sort of review what trials we do have and how these were studied and what results we saw in what we call the pivotal trials. So, these are the trials that were done for FDA approval. And so, the first to market, the first to go through the FDA process was fezolinetant, or Veoza, as we all know it now. And their pivotal trials were called the Skylight trials. So there were Skylight 1 and 2, and they were the same trial, identically designed phase 3 randomized double-blinded placebo-controlled trials. So they ran from 2019 into 2021. And women aged 40 to 65 years with an average of greater than 7 moderate to severe hot flashes a day were eligible to randomize. They had to be in good health with no contraindication to hormone therapy. And that's an important thing because
Yeah.
the FDA required that because when the first one came out, especially, they felt like they weren't sure it wasn't in some way hormonal. So they wanted to make sure that that was sort of a safety mark for them. So this was not tested in breast cancer patients or other cancer patients. It was in women who could have taken hormones, but for whatever reason didn't. Um, these women randomized into 3 groups, 1 to 1 to 1. So there was a placebo group, a fezolinetant 30 milligram group, and a fezolinetant 45 milligram group. Um, and they treated them in this 1 to 1 to 1 randomization for 12 weeks. And then they followed that with a 40-week active treatment extension, which means the placebo participants were then re-randomized to get either 30 or 45 milligrams, and they followed them out for 40 more weeks. And the primary endpoints were decrease in severity and frequency of vasomotor symptoms at 4 and 12 weeks. What they showed in these studies, pooled, is that fezolinetant 45 milligrams decreased. They reported the decrease in vasomotor symptoms as least squares difference, which makes no sense clinically. So it's since been translated to an approximate 50% reduction in frequency from baseline. And pretty similar reductions with the 30 milligram dose. And then in terms of severity, um, the reduction was on scales, again, least squares reduction was by 0.29, which was statistically significant versus placebo. Um, those results were observed as early as day one for patients
Oh,
taking the
wow.
treatment. And they showed in this study, the reason they did the extension was they showed there was no real tachyphylaxis. So people didn't
Mhm.
suddenly start having hot flashes again further in. And then at week 12, they also did what they call a responder analysis. So they asked people if they felt that they had reduced their hot flashes by at least 50%. And almost 60% of participants on the 45 milligram dose felt like they did. And 36% on placebo also felt like they had reduced their hot flashes by 50%. Now, that's different from the data that they collected in diaries. So they had women during the 4 and 12-week mark actually noting each and every time they had a hot flash. So they
Mhm.
could count them, but it's interesting that, the impression of the women, even in the placebo group, was for pretty good
Pretty high.
results. It's
Yeah.
pretty high. We always see that, right?
Yeah.
And then they also did a menopause quality of life survey and found that the women on the 45 milligram dose had a more improved quality of life than those with placebo, and that was statistically significant as well. They looked at sleep disturbance, but sort of got
Mhm.
mixed results. So the Skylight one did not show improvement in the main. So there's a survey for sleep disturbance called the Promise Sleep Disturbance Score. And
Mhm.
in Skylight 1, they really didn't have an improvement in sleep disturbance. Skylight 2 showed a slightly significant decrease in sleep issues with the 45 milligram dose, but when you pool them together, they sort of did an interesting analysis where they pulled everybody and then pulled out only people who are unsuitable for hormone therapy and said in that group, they showed some improvement in sleep disturbance. So I'd say the data is not strong for sleep
Mhm.
with the fezolinetant. And then of
So,
course,
can I
yeah,
ask a quick question
yeah,
here? So, as far as 45 milligram versus 30 milligrams, so what I'm hearing from Skylight One is that
hmm
objectively speaking, there wasn't major differences between the 30 and the 45, but subjectively there was, and that's
yeah,
why they decided to go with 45.
yeah. Actually, interestingly, before
Uh-huh.
this, there was actually phase two studies where they did 30, 45, and 60 milligrams.
Uh-huh.
60 milligrams worked great, but that leads me to the next point, which is liver
Uh-huh.
safety.
Okay. Yeah,
And
exactly. That's the
so
scandalous thing here. Yeah.
yes. So as we all know, there's some issue with elevations in ALT or AST. And in the actual trials, there was approximately 1.5 to 2.3% of women treated had some elevation in ALT or AST. And they were looking specifically for those being 3 times the upper limit of normal. So
Mhm.
somewhere between 1 and 2% of women reached that 3 times the upper limit of normal. Those elevations were asymptomatic, transient, and resolved. So there were no severe drug-induced liver injuries reported in any of the trials. And so one of the reasons the 60 milligram didn't go further beyond phase two is because it was actually higher than that they saw the
Mhm.
liver function issues.
Yeah.
Many in the phase two trials, they actually didn't discontinue the medication for some of the liver
Mhm.
failure, and it still resolved even while staying on medication. But the in phase three, they always discontinued if somebody had a liver function issue. And all of those patients did resolve. But, we'll talk a little bit later about, prescribing practices and what you have to do to prescribe these. And that's where the concern over liver safety really comes in. So that's sort of a summary of the basic trials that we have for Veoza or fezolinetant. They have been doing some post-marketing studies looking at comparing it to things like SSRIs and other forms of
Mhm.
treatment. Those data are not out yet, so we don't really have that. And I think they're looking deeper into some of these other things like sleep and things like that. So hopefully we'll continue to get data from the research group. So let's talk a little bit about our new player, which is elezonitant or Linquet. Don't know how they came up with that name, but they did. Um, Anyway, so Linglet was studied, or elezonitant was studied in the OASIS trials. I love how they come up with these names. So again, OASIS 1 and 2, identically designed phase 3 randomized double-blind placebo-controlled trials. And then they also actually did OASIS 3, which was actually a planned 52-week fully placebo-controlled trial. So they actually have three populations that we can look at. So the OASIS 1 and 2 were that same 12 weeks, and then they gave them a 14-week active extension, but OASIS 3 actually followed them for a full year. And then again, similar population. Again, the FDA required that they not have contraindications to hormone therapy, at least for US trials. We'll talk about what was done in Europe. And, just so everybody knows, the FDA didn't believe these were not hormonal. So in all of the trials I'm talking about, we actually had to do beginning and end endometrial biopsies on these women. So kudos to the women who stuck it out and got two unnecessary endometrial biopsies for the sake of science. Just going to say.
Was there any abnormalities?
No.
Just out of curiosity. Okay.
No. Because they're not hormonal.
Yeah.
Anyway, so once all the data came in, so at week 12, so in OASIS 1 and 2, they showed a significant reduction in vasomotor symptom frequency. They also did least squares mean difference, but it was bigger than that seen with fezolinetant and translated with a reduction of approximately 65% in VMS frequency versus 42% with placebo. And in OASIS 3, they saw a 73.8% reduction from baseline versus 47 with placebo. All the studies showed improvement in severity with a reduction in 0.4 and 0.3 in the least squares mean differences. And then again, onset of effect was within the first week in all of the trials. And then they looked at through 26 weeks in OASIS 1 and 2 and through 52 weeks in OASIS 3 and didn't see any tachyphylaxis. So patients continued to have good benefit. Their responder analysis showed that by week 26, more than 80% of participants felt that they had achieved at least a 50% reduction in VMS frequency. Both in the continuous ones and in the ones who had gotten switched from placebo. So the people who had been on the med the whole time were at 84.5%, and the ones who went from placebo to the medication felt like they, at 86.7% of them felt like they had a reduction. Where they differ is that elezonitant did do the sleep studies, the sleep surveys, so the PROMIS sleep disturbance short form, and they showed a pretty significant decrease in sleep symptoms in OASIS 1 and 2. And they showed that participants with mean scores, the participants' mean scores in general improved from moderate sleep disturbance at baseline to the normal range with elezonitant, and from moderate to mild with placebo. Because there's always some placebo effect with these things, right? You're doing something to treat yourself, you're going to feel better. But definitely a significant difference in sleep benefit. That definitely needs more study, but it's an interesting piece of this puzzle. And then, of course, we need to talk about liver safety. So in all of these trials that we've now discussed, there have been no liver enzyme elevations that got over 3 times the baseline. So no cases of toxicity or hepatotoxic effects from this drug. And because of the fezolinetant experience, they were actually subjected to a liver safety monitoring board, and they saw no events. So that's reassuring. They also did, I don't know what they ended up calling it. When it was first coming out, it was called OASIS 4. They trialed Linglet in breast cancer survivors in Europe. So the FDA would not allow them to do that here, but it was done in Europe, and they showed similar reductions in VMS frequency and severity in those patients. And these were patients who were allowed to be on tamoxifen, aromatase inhibitors, or no treatment. So with no safety issues identified in that study. So it gives us a little bit more information for our breast cancer patients because I know when Veoza came out, there is a little bit of interaction between
Mhm.
aromatase inhibitors and Veoza in terms of processing. So you're probably getting slightly higher Veoza levels in those patients, but that is not the case with Linquet. It has no, they don't share liver pathways for processing.
So, quick
And
question there.
yeah.
So, on the breast cancer patients, so if you had a patient, if you had a Veosa patient,
Mhm.
a breast cancer survivor on AI, then you are not prescribing Veosa?
So since it's been out, they felt that it is okay to do with the caveat that there probably is a little bit of interaction. The AI is
Hmm.
probably decreasing the processing of the Veoza, so they're probably getting a slightly higher dose. So they might actually get better results because we know the 60 milligrams works great. But you
Right.
just want to be thoughtful about that. And when we had no other choices, I was willing to do it, but now we have other
Hmm.
choices.
Right. Okay. Got it.
And then the last thing I wanted to bring up was that they obviously we talked about the endometrial biopsy stuff, but bone loss was also looked at with Linquet. And
Hmm.
they looked at bone loss over the course of the study, and they showed no more than the normal age-related loss. So it's not impacting bone metabolism one way or the other. Um, they did do one sort of systematic review meta-analysis where they tried to compare them side by
Hmm.
side. And what they did in that is they controlled for the differences in the studies before making the comparison, which I'm not going to go into the details of that. But they felt
Hmm.
like for VMS severity and frequency, they had about equivalent efficacy profiles.
Hmm.
Um, and Elizanitant might have been a little bit better on the severity reduction, um, and a little bit better in the responder rate. And then they say it's definitely superior in terms of sleep disturbance improvement. Whew, that was a
That
lot.
that was a lot. I was gonna say. So is there based on what we've heard, is there
Mhm.
any reason that someone would favor Fezolinetant to Elazonitant? I hope I'm pronouncing that one correctly. Because it seems like, Linquat is
Mhm.
superior as far as, same for vasomotor symptoms, superior for sleep quality, less effect on the liver, totally acceptable to use in breast cancer survivors with AI. Is
Mhm.
there any advantage that Fezolinetant has over Elazonitant that's, you
I
might
think we have
consider?
a few more years of experience with it. So there's
Uh-huh.
that. And I know there can be a comfort level with that. I think
Yeah.
that it will probably get insurance coverage first because
Mm-hmm.
it's been trying longer.
Right.
Um, Beyond that, in my mind, not really. I
Yeah.
tend to favor Linquet in my prescribing.
Okay.
Do you want me to talk about comparing it to sort of other medications, or would you like me, or do you want to
No,
talk
go
about it?
ahead. Yeah. I'm
All
listening.
right.
I'm loving it. I'm loving this.
So there are a couple of studies that have looked at, and they're comparing apples to oranges to a certain extent, but they've tried to look at these
Okay.
drugs compared to previous things that we had. So whether that be SSRIs or gabapentin, things like that. And when compared to the main SSRIs that we see used, so like paroxetine,
Mhm.
venlafaxine, desvenlafaxine, the difference in severity and frequency is pretty significant. So fezolinetant compares
Mhm.
very favorably to those medications,
Mhm.
as well as to gabapentin. So it definitely shows significantly more reduction.
Right.
um, and then elezonitant, because of its effect size being slightly larger, shows even more favorably against these older medications that we've been using. The the other thing to keep in mind is that we haven't done a direct head-to-head with hormone replacement therapy, right? So if you have a
Mhm.
patient for whom both are an option,
Mhm.
um, there's been some talk about the fact that yes, there's a certain amount of reduction in hot flash severity, but it doesn't meet what some people consider a minimally important clinical difference
Mhm.
for hot flash and hot flash related quality of life, whereas menopausal hormone therapy does a lot better in quality of life measures. But I think, the thing to
Right.
keep in mind is that fezolinetant is treating one thing. It is treating hot flashes.
Right. Right.
Menopausal hormone therapy has a lot of accessory beneficial effects, so it's going to perform better in quality of life surveys. So,
Right.
it's all about balancing those things. And the other thing to keep in mind is that, these probably have a pretty favorable safety profile when compared to some of our
Mm-hmm.
older medications. The SSRIs that we use have some pretty significant side effects for patients in terms of sexual dysfunction, weight gain. There could be a lot of drug-drug interactions. So many of the SSRIs that we use for this actually interact with tamoxifen and are inappropriate for breast
Right.
cancer patients, which I don't think a lot of us recognize. So, and gabapentin can be really sedating. So if somebody's having a lot of daytime symptoms, that's not
Mm-hmm.
going to be a great choice for them.
Right.
Clonidine never really shown to have benefit. In fact, the Menopause Society took it out of recommendations in their latest non-hormonal recommendation. So these seem to have a lot fewer side effects and as good, if not better, vasomotor results. So, I think in general, this is a real step forward for us in treating women with severe vasomotor symptoms who otherwise can't use hormones.
Yeah.
But
Yeah.
in order to use them, Hannah, we have to prescribe them and get them into the hands of our
And,
patients.
and
And
therein
what are we
lies the
seeing with that?
problem. Oh, nothing good, nothing good.
Yeah.
So, on a serious note, both of these medications are profoundly difficult to prescribe in the sense of getting insurance coverage.
Yeah.
Personally, I'll tell you, I have not had good luck with
Mm-mm.
either of, well, actually, I haven't even tried the Linquat yet, but I have not had very good experience with trying to get Veosa covered for my patients. So, Fezolinetant has poor insurance coverage. We know that. There is a manufacturer coupon. So, there's a savings card, a Veosa savings card. It can be used in patients who have commercial insurance. And it does offer the first month, first month on us. So, it's $0 for the first month and $30 monthly thereafter for a maximum benefit of like $4,000 a year. And then you have, if your patient is willing to pay out of pocket, so the without insurance cash price is roughly around 550 a month for Veosa, so that runs you around 6,600 a year, which is quite a lot. That's half of a month of GLP-1, right?
Yeah. The
And
other thing to keep in mind is when they're
yeah,
calculating that $4,000 per year maximum benefit on the manufacturer coupon card, it's
yeah,
about $500 a month because they're
yes.
deducting it from the cash pay price. So patients really only get like 8 months of medication with the card per year.
Correct. Yes. And I've had that experience where I had several of them who were able to get the first month
Hmm.
totally free and then had the hardest time beyond that. And so we had to kind of scrap that and think of other
Hmm.
plans. Um, Now the uninsured and underinsured patients, there are patient assistance programs that can potentially, you can get the medication for free for your patients. I don't, have you had good luck with any of these
I haven't tried.
programs?
Honestly, I
Okay.
haven't tried. Yeah.
Yeah, I was gonna say because I haven't tried either, so I don't know whether that works or not. But regardless, if you're planning on using a savings card, just know that it's not valid for patients who have any sort of state or federal insurance. So your Medicaid and Medicare patients, no go there. So the bottom line is it's a lot of hoops to go through. Most insurances will not cover. As far as the savings cards, usually you can get away with prescribing for 1 month and maybe you can get them on low cost for like 8 months or so, and then after that it becomes really problematic. And then on the Linquat side of things, so I haven't prescribed it
Oh,
yet, but I know,
maybe I should
yeah,
speak to this. I have.
yeah,
So
okay,
I've used it in a
yeah,
couple of patients. So
uh-huh,
Linquet, they took a different approach. So they're distributing all their medication through Blink RX, which is an
uh-huh,
mail order pharmacy.
Uh-huh.
And so if you have to prescribe to BlinkRx, it's not actually in the local pharmacies. If you prescribe to BlinkRx, they will check the coverage, which will be none at this point.
Right.
They have you do one prior authorization. The goal there being that they're trying to signal to the insurance companies that this is a needed medication and what those indications are. It's going to be denied. And then they will give the patient the medication, they will mail order the patient the medication for $25 a month. They have promised that they will continue this price through the end of 2026. We don't
Mm-hmm.
know what will happen from there.
Yeah. Yeah. And then there's also, the other big part of all of these
Mm,
medications is the LFT situation. So LFT
right.
liver function testing, right? So both have LFT requirements. The fezolinetant requirements are a little more cumbersome. So
Yeah.
when it first came on the market, it was like, what was it? 0369, right? So you
Hmm.
need LFTs at baseline after 3 months of use, 6 months of use, 9 months of use.
Yeah.
And then they did a loop to do there, and the FDA decided actually that's not enough LFT testing. So then that got changed to if you're on Veosa, you need baseline LFTs, then LFTs at the conclusion of the first month, the second month, the third month, the 6 month, the 9 month.
Yeah.
And essentially, you will discontinue these medications if your LFTs are beyond threefold of normal.
Yeah. They actually say
And
some, a lot of
yeah,
people are just continuing beyond twofold of normal to not get to
twofold of
three.
normal.
Yeah.
Okay, got it. And then, to my understanding, is that there haven't really been any cases of liver failure
No, none.
with
None so far.
with
Yeah,
none
the
so
FDA made
far.
the change because there was more like the percentage of people having some liver function
Yeah.
changes was higher than they were expecting in post-marketing, but no one has had liver failure as far as we know.
Right. And I think Linquet testing is or requirements are less
Much
are,
less.
are
Yeah.
less strict, right? Yeah,
Yeah,
yeah, yeah. So it's like baseline and then 3 months, and that's pretty much it, right?
that's it. And that's based
Yeah.
partly on the fact that their studies didn't show any liver function impact,
Mm-hmm.
but both sets of
Yeah.
like the fezolinetant liver impact seems to happen in the first 30 days. So the FDA is feeling fairly comfortable that if it's going to happen, it'll happen in that 3 months.
Right, right. And then also to, to add complexity to the situation is ordering the LFTs, right? Because if the drug is not covered, then you run the risk of the patient being charged or ending up with a bill for
Hmm.
the cost of the LFT that you need to continue them on the medication. So probably the best coding would be like a Z79.899, right?
Yeah.
Long-term use
Hmm.
of drugs.
Yeah.
And you can sort of try and combine that with the N95.1 ICD-10 code
Yeah.
to get some coverage. But honestly, it's been all over the map as far as Veoza goes.
Yeah.
I've had it's been a mixed bag. So it's not smooth sailing,
No,
but definitely like a very valuable class of drugs for that cohort of, specifically when we start talking about breast cancer survivors and women who have like strong contraindications to the use of HRT. Yeah.
absolutely. Yeah, no, I think it's a huge boon to us in this
Mm-hmm.
field to have
Mm-hmm.
another tool in our toolbox.
Yep.
Is it a perfect tool? No, but it's better
Yeah.
than the tools we had before.
That's true. That's
We got the
true.
newer hammer.
Yeah. I like that. The
So
newer
there are a
hammer.
couple, we're going to open it up for questions and comments. I did see a comment in the chat that when you prescribe Linquet to BlinkRx, you prescribe for 30 days. That's correct. Don't prescribe 90
Mm-hmm.
days. They won't fill 90 days. You got
Mm-hmm.
to do 30 days at a time and they will fill it that way. Can you use either with hormones? Excellent question, and I'm glad you brought it up. So, we don't have a lot of data on elezonitant with hormones. I'm not sure why you would. I would just titrate my hormones to
Mm-hmm.
solve the VMS and other symptoms. With Veoza, we do know that estrogen potentiates Veoza. So if you're to use not vaginal estrogen, but systemic estrogen will potentiate
Right.
Veoza, which means you will get higher levels of Veoza. So not really recommended because at higher levels, obviously, we have a higher risk of liver function changes.
Liver issues. Yeah.
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 But more importantly, I think It would rarely make sense to use the two together because the beauty of hormone therapy is that we have a huge range of hormone doses that we can use. So we can just titrate patients to good symptom relief, and the hormone data is probably better. So, at
Well,
least
I
in terms
guess,
of quality of
that
life.
right. I'm thinking maybe every once in a while we'll get that patient who we've maxed out, right, on HRT and they still have the VMS. And
Yeah.
I guess maybe then I would think, oh, maybe this would be a good option. But I don't know. I'd make the argument that potentially like an SSRI addition may make sense and also review
Mhm.
the medrec to see if there
Right.
are other, right, medications that are contributing to these VMS symptoms that
Absolutely.
are not resolving.
Yeah,
Yeah.
absolutely. I review sort of what they're on. If
Hmm.
they're on a transdermal estrogen, I will often check levels like day one of their patch to make sure
Yeah,
they're actually absorbing
yeah,
transdermally. Not everyone is an excellent transdermal estrogen candidate. And if they're
right.
not really absorbing, then we talk about switching to something else, like an oral
Like
or
an
a
oral.
femring. Yeah. So there are
Hmm.
a lot of
Yeah.
steps I would go on before. And,
Hmm.
maxed out is a relative thing. In some of my
Right.
younger menopausal patients, I've gone as high as, zero point 0.2 in patches or the equivalent of 4 milligrams
Right.
of oral estrogen a day, because sometimes when they're younger, especially going into an early menopause, they just need more.
Yeah. Yeah.
Other
Right.
questions? Let's see. We've got the chat and the Q&A that people can use. I'm checking both right now. All right. Well, let's chat a little bit longer to let anybody write in a question if they have one. Trying to think what else we can talk about with these medications. I've had, in terms of like personal experience,
Hmm.
so obviously I have some inside knowledge with the trials, and
Hmm.
definitely it was interesting to see with the elazinitant trials that we were hearing
Hmm.
that sleep was getting better out of proportion than you would just expect from having fewer nighttime hot flashes. Like people felt like the quality of
Right.
sleep was better. They weren't waking in the middle of the night, even, the wakings that they were
Like
having that were
unrelated to night
unrelated.
sweats.
Yeah,
Yeah.
yeah. And then in the few patients I've used it in practice now,
Hmm.
it's it's definitely had a good impact both on VMS and sleep. I have a couple of patients who are very, very happy on Veoza, who've never had any issue
Yeah.
with liver function, and they're a year and some in and doing great. I have heard rumblings, though, that some
Hmm.
people do seem to get tachyphylaxis. So at some point, the effect starts to wear
Beyond
off.
like a year, or what if you've
Beyond like a
seen
year,
or
because
heard?
now we're getting
Okay.
into having a couple years of data,
Hmm.
right? Which we don't have
Yeah.
from any of the
Yeah.
studies. So,
Yeah.
it'll be something that we'll continue to monitor. Both of these companies are doing extensive post-marketing studies and
Hmm.
watching these
Hmm.
patients, and they want this data. So I think we'll continue to have publications and information. Someone eventually will compare them head to head.
Right.
Somebody will run it
Are,
head to head with hormones, hopefully.
yeah. And are there any that you're aware of, any new NK receptor antagonists that are being developed, or no, that's pretty
I
much it?
think these are the two we're going to get.
Yeah, so we're not gonna get one that also treats like low sex drive.
No.
And then
Wouldn't that be awesome?
and
Man.
then we'll be like done, done. Yes.
Now we're done.
Now we're done.
That's all we needed.
We've
Thanks.
we've solved menopause.
Yes. No, I don't know of any others in development. Certainly none that are in phase 3, or
Hmm.
even phase 2 that I've seen. And I do tend to keep an eye on that market and what's going around. There are new drugs for hot flashes that are being developed,
Hmm.
but they're not in the NK range. I know there's one that we did the phase 2 for that's sort of on a monoamine pathway in the brain. So still looking at brain chemistry and how do we alter that. They're going into phase 3. They just announced their top line results from their phase 2 trials. So,
Okay.
there's things being developed, but not
Yeah.
that I've seen in the NK region. No.
Yeah. Yeah, my experience has been fairly good with Veosa.
Hmm.
And I guess in general, it's a good experience for patients because, again, usually I'm not giving people Veosa unless there's a clear contraindication to HRT, right? So
Hmm.
they're just grateful to have something that
Yeah.
is actually helping with the
Hmm.
VMS.
Yeah.
So, in general, I have a happier like patient cohort there.
Yeah.
So,
So we had a question if estrogen will potentiate the linquet also, not that we know of. So much like the Veosa interacts with tamoxifen, it also interacts with estrogen. Linquet seems to be processed through a different pathway in the liver. So I have not seen any data that estrogen potentiates that. I'm not sure how closely we've looked, though.
mhm.
I'll be honest. So, you know, things still to learn, and we will
Yeah.
continue to learn.
Yeah.
All
And
right.
how old is Linquit now? Is it
I came out like
6 months?
6 months ago. Yeah, I think
Yeah,
November.
that's what I
It came
thought.
out during the
Yeah,
Menopause Society meeting, remember?
that's true. Yeah.
Yeah, so October. It came out
Yeah.
in October 25 to market. They got
Yeah.
their
So
approval
we
then
still
and
have
they
a
got
lot
it
to
right
learn.
out. Yeah.
Yeah.
So, yeah. So we're just starting to get the post-marketing data, and that'll take
Hmm.
years to come through,
Hmm.
and then we'll know more about it. These will be old
Yeah.
hat soon. I will say, in terms of prior authorizations, I have had a couple of successes with Veosa just this year
Uh-huh.
in my breast cancer patients. So, maybe we're starting to get some headway. I don't know.
Sure.
So, all right. Well, everybody, I'm so glad we had this conversation tonight. Thank you, everybody, for coming. And thank you so much, Hannah, for having this conversation with
Yeah.
me. Yeah, it's
Thank you
always
for
fun to talk to you.
inviting me. Yeah.
And if people have other questions, feel free to sort of reach out to us. Tell your friends who you think might benefit from this. It'll be on our YouTube channel in the next couple days. And it was great having a conversation. Good night, everybody.
Take care. Bye.